Pleasure to introduce the first speaker for this afternoon, Joseph Yu.
Thank you, Ken. What we've done is we've decided to divide some unusual topics. My topic is going to be non-cardiac chest pain and musculoskeletal considerations. I have no financial disclosures to make. Just a little bit of background. Chest pain is one of the most common symptoms encountered in the emergency room. And although our top priority is always to exclude life-threatening conditions, I think it's important to remember that the majority of patients that come in with chest pain actually have benign conditions. In fact, about 13 to 50% of patients who initially present to the emergency room with chest pain, initially considered to be of cardiac origin, actually will end up leaving the emergency room with some other diagnosis. And in many of those patients, they will fall in the category of painful chest wall syndrome. Now, recall that in the United States, about 5% of patients have the diagnosis of fibromyalgia, and it's noteworthy that about 55% of these patients will eventually present to the emergency room with a non-cardiac chest pain event. So the objectives of this course is going to be to review the anatomic considerations that pertains to the chest wall, discuss some musculoskeletal conditions that present with pain or can mimic those that may be potential sources of pain. We'll talk about some differentiating imaging findings and ultimately review some risk factors. So when we talk about the bony thorax, let's go ahead and start with the ribs. Ribs are designated by their anterior articulation. So most of us have 7 true ribs articulating to the bony sternum, 3 false ribs that attach to the sternum via the cartilage tissues, and 1 or 2 floating ribs without an anterior articulation. When we think about the posterior articulations, about ribs 2 through 10 articulate with 2 adjacent vertebral bodies through either the costotransverse joints or through the costovertebral joints. Lower down, certainly at rib number 12, but also in the 11th thoracic vertebra, the rib may articulate through only a costovertebral joint and hence only have 1 attachment. In between the ribs are the intercostal muscles, and of course the neurovascular bundle courses directly beneath the rib. So when we think about potential causes of pain arising from the rib cage, of course we think about rib fractures, stress fractures, and rib tip syndrome, but also the cartilaginous tissues may be sources of pain, and we'll go over these conditions. Now in the chest, there are a number of normal variations, and many of these are benign, but some of them can cause symptoms. The cervical rib, for example, is seen in 1 out of 200 people. And these usually articulate with the cervical vertebral body. And notice that in the cervical vertebral body, the transverse process is more horizontally oriented, in contradistinction to the thoracic transverse process, which has a more oblique orientation. Now note that the ribs can either be hypoplastic, normal size, or relatively large. And therefore, in some patients, you can have symptoms, and in fact the literature is quite generous in telling us that 1 in 10 people will end up having some type of symptom, either pain, swelling, or weakness. So we know that the cervical rib can cause symptoms because the anterior scalene muscle can form a sling with the rib, causing impingement of the vascular structures, usually the subclavian artery or the vein. But they can also, as the cervical rib enlarges, also displace the brachial plexus and cause elevation, causing traction abnormalities. Now, for most of us, the majority of pain syndromes is going to be related to blunt trauma, either from direct impaction or from potentially compression injuries. But the most important thing about these that we have come to recognize that in addition to the fractures and dislocations that occur, we need to be very cognizant of potential intrathoracic soft tissue injuries, particularly vascular, and also craniocerebral and spine trauma can add to the morbidity of the patient. So ultimately, when we review these patients with CT, we're looking for other clues such as soft tissue injuries. If we have the opportunity to see the patient, to look for the ecchymotic signature pattern, and of course the presence of pleural effusion and pleural reactive changes. Now, lateral impaction injuries to the chest can also result in rib abnormalities, and in those people, because the fracture occurs laterally, may require rib series for us to be able to identify the fracture. And remember that in these patients too, depending on the force of the injury, there may be intrathoracic abnormalities. Now note that this patient has a fracture, the transverse fracture of the scapular neck. Now it requires tremendous force for a patient to sustain this kind of injury. So when we evaluate these patients with CT, typically we'll see displaced fractures, but we also have to be very careful not to miss non-displaced fractures that will be certainly radiographically occult. Now when you look at patients with polytrauma, if their fractures occur lower in the thoracic cage, you have to be very careful to evaluate the underlying viscera, particularly the liver and the spleen, since these fractures can be associated with significant splenic or liver lacerations, as well as diaphragmatic injuries. Now, moving on to stress fractures, when we think about stress fractures of the chest cage, the thoracic cage, we're really thinking about athletes because they're the ones who usually will be involved in a situation that will result in overloading of the bony structure. So it will be either a movement that causes a lot of rotation or twisting. And in one of the classic papers that has been described, 12% of elite rowers will actually present with some type of stress fracture sometime during their competitive career. So OSU won the national championship in crew this year for women's 8 rowing type of a boat. And in this patient, the majority of these patients get their stress fractures during the winter training. That's when they really accelerate their resistance training. And this patient had persistent pain in the left side of the chest, and notice that there's 2 fractures here in the posterior lateral aspect of the rib. Most stress fractures, as you know, wherever it is in the skeleton, is now felt to be related to an imbalance of the muscular strength. So when we think about fractures in the first rib, it's usually the scalene muscles, and in ribs 2 through 9, we're thinking about the to and fro motion from the serratus anterior and the external oblique muscles. Although seen in young people, we always have to consider the possibility that metastasis may also be occurring in this group. Now, when we think about first rib fractures, this is really the most commonly reported athletic stress fracture in the thoracic cage, and this is related to the scalene muscles which insert on the anterior aspect of the first rib. And because it pulls that anterior rib, it usually fails in the subclavian sulcus. It's a very important injury in elite and high caliber baseball and tennis players. And in fact, this patient happened to be one of our pitchers. And when we first reported him, we thought he was costochondritis until he had that very classic history of insidious pain followed by a pop and then the acute pain following that. Now, rib tip syndrome is something that clinicians are very aware of, but radiologists not so much. And notice that he goes by a number of different names. And it really constitutes a very small percentage of people with chest pain syndrome. And this is caused by hypermobility of ribs 11 and 12. And if you throw in insufficiency of the fibrous attachments of ribs 8 through 10, what can happen is that the floating ribs can then insert themselves underneath the adjacent superior rib and irritate the intercostal nerve. They have this very classic triad of clinical symptoms: stabbing pain for a short period of time, usually minutes, followed by more lasting aching. They will have tenderness and pleurisy with bleeding, and they also have pain with palpation. The key take-home message with this syndrome is that all of the imaging will be normal, and their cardiac workup will also be normal. So when you have an extensive amount of imaging, but everything turns out to be normal, think about this particular entity. And the way you make the diagnosis is through clinical examination. You put the asymptomatic side down, you grab onto the costal margin, you pull up. Occasionally you'll feel a click or a pop, but you can recreate the pain. Now, costochondritis and cartilage fractures are the main differential diagnosis. Costochondritis is very, very common. In fact, in family practice literature, About 40% of patients that come into an office with the symptom of chest pain, they will walk out with the diagnosis of costochondritis. Now, a lot of people use costochondritis and TT syndrome as synonymous, but in fact, TT syndrome is quite rare. It is an inflammatory process that causes significant swelling. It's usually younger people, and it usually affects only one rib, usually ribs 2 or 3. Costochondritis, on the other hand, usually affects multiple ribs, usually from 2 to 6, and there is no soft tissue swelling. Now, the etiology is not known, but it's felt to be related to repetitive activity that causes separation of the cartilage from the actual bone. We know that this is an inflammatory process because this gallium scans results in a positive scan. And during that time when it is positive, MRI will also be positive, showing edema at the junction between the cartilage and the rib, as well as periosteal reactive changes shown nicely from this article. Now, costochondral fractures, kind of in the same family, but these patients come in with acute pain. So when on the left side, it can mimic those of myocardial infarction. There are 2 etiologies, either direct trauma, which is really easy to ascertain, but those that are from indirect trauma or overuse from sudden contraction of the oblique abdominal musculature, much more difficult to diagnose. This patient fell on a fence. That's a very typical history. It may be someone who's riding their bike and falls off their bike and hits their chest. And the CT is quite diagnostic. Notice that there's fractures of the cartilage of ribs 6 through 8 on the right side. So not a very difficult diagnosis, but the thing to remember is you have to look very far anteriorly, and you have to window the images not only for the bone, but for also the soft tissues. Here's another patient. This is a professional mixed martial art athlete, and he was kicked in the chest, and he had persistent pain for 2 weeks that kept getting worse because he continued to train. And notice that in the anterior aspect of rib 5, he has this very characteristic fracture with fluid filling in between the 2 ends of the cartilage. Now, moving on to the sternum. The sternum is made up of 3 particular parts: the manubrium, the body, which is made up of 4 segments, and the xiphoid, which is quite variable. The manubriosternal junction is an important landmark clinically because it identifies the second ribs, and we know that the sternoclavicular joint, our synovial joint, containing fibrocartilaginous disc within its joint space. So the considerations for pain in the sternum include stress fractures, traumatic fractures, both low and high impact, as well as diseases that affect the joint, including those that can be inflammatory and related to arthritis. Now, in the sternum, there are a number of variations. The pectus excavatum is actually the most common deformity of the anterior chest, and this very characteristic central depression is the result of overgrowth of the cartilage from the inferior aspect of the chest. It allows the lateral portions of the rib cage to bulge out anteriorly and gives this very characteristic central depression. And most people, when they become symptomatic when their pectus index is above 10, severely when it's in the magnitude of 20 or 16. We all know what the radiographic manifestations are. They're quite characteristics. Usually best seen on the lateral view. The prevertebral space is reduced. You have this very characteristic concavity. It can be low or it can be high. But the axial images really tell the story of the abnormality. You have the central depression with the overgrowth of the cartilage from both beneath and both sides. When very severe, you can see how it can cause marked narrowing of the anterior and posterior chest wall and the left cardiac displacement, as well as rotation and markedly diminished left lung capacity. Less commonly is the pectus carinatum abnormality. These happen to be more common in men, usually associated with some degree of scoliosis, and there are 2 types. The chondromanubrial deformity is in the upper chest, involving the upper sternum, and the more common is chondrogladiolar deformities, either affecting the middle portion of the sternum as seen here, or slightly lower down as seen here. There are also other normal variants that you need to know about. The sternophoramen can be seen in anywhere from 5 to 8% of the population, and these are simply holes in the sternum from failure of the paired mesenchymal pairs fusing in the midline. They're always in the midline. They're usually circular or ovoid in shape, but they can mimic a lytic lesion. Sternal bands are also in the midline. They can look like low signal intensity or sclerotic areas within the bone, but they can sometimes mimic stress fractures. And of course, xiphoid clefts and foraminals can look like destructive lesions on radiography. Stress fractures are relatively uncommon in the sternum. There are classically two different types, one from osteoporosis resulting in progressive thoracic kyphosis, and the other is in athletes. They have bulky musculature that are always competing for their space and pulling the sternum in different directions. We expect the bone scan to be positive. Notice that on MRI, 3/4 will occur in the body and about 25% in the manubrial-sternal junction. So let's take a look at what they look like. Here's one of our collegiate athletes. Right before the Big Ten tournament, he started complaining of anterior chest pain, and that just kept getting worse as he continued to train. We took a sternal series and we saw this linear lucency, and the big question is this an open synchondrosis or is this a stress fracture? Sometimes you can't tell. Many times even an open synchondrosis may be symptomatic. So the MR is diagnostic. There's intense bone marrow edema. There is irregularity of the cortical margins. So this is very prototypical of a stress fracture between the first and second sternal segments. Here we have a little older weightlifter. Every time he did deadlifts, he would adjust his back because he also had Sherman's disease. And in so doing, eventually he felt a crack in his chest, and he ended up with a very classic manubrial-sternal stress fracture. This was one of our bodybuilders. He used to do box squats, and when he would sit on the box, he would lean forward and then he would lean back. Every time he leaned forward, he would put tremendous pressure on his chest. The manubrial-sternal junction would bulge out. So stress fractures in the sternum often is the result of improper training in our experience. This is the classic osteoporotic stress fracture where you have a compression deformity in the dorsal spine. You have an exaggeration of the kyphotic curvature, and eventually the sternum will fail where the initial stress fracture occurs. So this is what it would look like when it's pre-fracture, when it's beginning to bulge out, and then with very minimal trauma, you can see how this can complete into a fracture, and the patient will present with chest pain. Now, when we think about traumatic fractures of the sternum, the location of impaction is important. Crushing injuries low in the chest will result in fractures above the level of impaction, and they have a very characteristic configuration. The inferior fragment will displace anterior to the superior fragment. So when you see that, you need to look at the CT of the abdomen quite closely because that's where the abnormality, the serious injuries, is going to occur. You can also get a type 2 manubrial-sternal dislocation. Again, similar manifestation. The inferior fragment will displace anteriorly and the superior fragment will move posteriorly. High compression injuries, on the other hand, will result in angular deformities at the level of the impaction. So here's a very characteristic steering wheel type of injury. Here's another one. And these result in angulated transverse fractures at the level of the impact. Sternoclavicular dislocation, although we've all been taught as medical students and residents to always look for that, is not that common, and it's actually somewhat difficult to miss nowadays. It does constitute 2 to 3% of dislocations of the shoulder, and anterior dislocations are much more common than posterior dislocations. And this is classically the clinical finding. You just have a bulging sternoclavicular region. The key is always asymmetry. So whenever you look at the chest x-ray in trauma patients, you need to look for the symmetry of the height and position of the clavicular heads. And CT is always diagnostic and pretty straightforward. So here you have superior displacement, disarticulation, and anterior displacement of the right clavicular head. Another example, this is a cone down view of a chest x-ray. So again, you have to really pay close attention to the chest x-ray. You see the asymmetry of the positions of the clavicular heads. The lordotic view was then called for and nicely shows the asymmetry in the height of the clavicles, and of course the CT is diagnostic, showing the medial displacement and the naked sternal facet. Now, posterior dislocation is the most common, the most devastating type of dislocation. Here the scanogram shows the asymmetry, but the key thing here is that you're going to have the potential for vascular injuries involving the carotid arteries. the jugular vein, the potential for tracheoesophageal tears, and of course traction injuries of the vagus nerve. So you need to carefully inspect that region for the potential injuries. One word of caution regarding clavicle fractures: we've all been taught the distribution is 80% in the middle third, 15% in the lateral third, less than 5% in the medial third. But that's only when you fall on osteochondral or when you have lateral impaction injuries. Most of the people that you're going to see that are coming in from an MVA will have anterior impaction. And those patients, the incidence of medial clavicular fracture is much higher, as much as 9%. And there will be other concomitant injuries, including rib fractures and intrathoracic injuries. And the key thing here is that they have a high mortality, up to 20% in certain papers. So when you see this abnormality in a motor vehicle accident, you need to really pay close attention to the CT of the thorax, look very closely at the intrathoracic contents, and make sure that you read the other studies, both the brain CT and the abdominal pelvis CT, for other potential injuries to the spine. Now, other miscellaneous injuries or conditions that can cause pain include sternoclavicular hyperostosis. Not that common, typically seen in men in their middle to elderly stage of their life, and often associated with SAPHO, and we're going to talk about that in a little bit. But these patients come in with pain and swelling, and the key finding is hyperostosis of both the sternum and the clavicle, as well as joint space narrowing. Bone scan will be positive, and CT is usually diagnostic. Coronal and axial images showing tremendous ossification of the periarticular soft tissues, as well as clavicular hyperostosis. It can be so dramatic that it mimics the neoplasm. And on MRI, we see low signal intensity changes on T1, variable edema on T2, and variable enhancement with gadolinium. Now, SAPHO stands for synovitis, acne, pustulosis, hyperostosis, and osteomyelitis. And recall that in these patients, the aseptic osteoarticular abnormality will involve the sternoclavicular regions in the majority of patients, as many as 9 out of 10. So you need to look for that, because in these conditions, the findings are very characteristic. You will have hyperostosis, you will have osteosclerosis and erosions, which can lead to ankylosis as well. On bone scan, there's a very classic finding in the sternoclavicular region, the Bose head sign, and you can see why that looks that way with the activity in the sternum, both clavicles, and occasionally the first ribs. Now, osteitis condensans kind of looks like hyperostosis, but it occurs more frequently in women, younger, from 20 to 50, and it's usually a stress-induced injury, so it's a loading injury. The characteristic finding is sclerosis of the bone, but notice that there's no joint space narrowing in the sternoclavicular joint, and it's felt to be a very similar manifestation as osteitis condensans ilii. And of course, bone scan and MRI will be variably positive depending on the stage of the condition. Now, here's a male carrier. She always carried her bag on the left side. Tremendous hyperostosis. Notice that on the proton density, you have nothing but low signal intensity changes. On T2, no marrow edema in this particular patient. Just a couple words about infection, because we know that in the emergency room, the two classic groups are going to be patients with indwelling central catheters or IV drug abusers. Very few other people will actually get osteomyelitis or septic arthritis of the sternoclavicular joint. Another word of caution: in patients with median sternotomy, as many as 2% of those patients may have an episode of osteomyelitis sometime during their course, and in those patients we always have to look for mediastinitis. So here we have a IV drug abuser. He also was HIV positive, had right-sided chest pain. We're trained to look for the septic arthritis, and here we see that we lose the conspicuity of the articular cortex. Bone scan is positive. CT scan shows the classic findings of septic arthritis with cortical regularity, widening in the joint, and the MR shows the enhancement of the bone marrow as well as the soft tissues. We tapped it, Staph aureus, very classic. Now, certain arthritic processes, particularly those that cause inflammatory synovitis, can also look like septic arthritis. So the bottom line in those situations, you really have to look at the patient's entire profile, including fever, constitutional symptoms, redness, as well as leukocytosis. Because notice that osteoarthritis, crystal disease, RA, they all like the sternoclavicular joint, and we know that. Now, the manubriosternal junction, we always think about seronegative arthropathies. And in the contravertebral joints, I just wanted to share with you a very interesting finding, because in patients with DISH, you can get hyperostotic changes in the rib. It can be quite dramatic, so that it looks like Paget's disease, because the cortex will be very thick. The bone will be enlarged, but you'll have the very classic manifestation of the hyperostosis from diffuse idiopathic skeletal hyperostosis. Now, this is a very typical patient. It was a Sunday. You have sclerosis of the bone, some areas of subchondral bone osteopenia. We have positive bone scan. And then the MR is done, and all you see is bone marrow edema surrounding the bone, as well as within the periarticular soft tissues. Notice that the articular cortex is still intact. There's no marginal erosions. The fibrocartilaginous disc is still intact. We still tapped this one, and we got positive birefringence. This is very prototypical patients with CPPD, or calcium pyrophosphate dihydrate disease. Just a couple words about muscle tears. Muscles are important in the chest, but notice that there are certain characteristic movement that results in injuries. For example, subclavius muscles, very typical in people that do pulling. So this patient was one of our weightlifters. He was a competitive bench presser. Persistent pain in his left chest, and notice that here we have interstitial edema in the inferior aspect of the sternal head. So this is very classic strain, grade 1 strain of the sternal head. So always look for the possibility that the muscles can be injured. One of the most challenging diagnoses is intercostal muscle injury. In these patients, you may have a bruising pattern that's fairly characteristic, but unless you're very lucky and you get the right projection with the MR, you may miss the myositis associated with the intercostal injury, as well as the periosteal edema changes. Now, there is an entity called epidemic myalgia. It is an infectious disease, so usually you'll have a group of people coming in with chest pain. They will come in with sudden chest pain, but they will also come in with other manifestations of infection. They will either have skin manifestations or an upper respiratory infection. It's Coxsackie-B viruses. I'd like to finish up with tumors. We know that that's kind of the first thing we look for in patients with chronic pain, but in patients with acute pain, you also need to consider, because in patients with pathologic fractures, those are the ones that are usually going to be the bad players, whereas benign lesions tend to be relatively asymptomatic. Now remember, the sternum is not a good area for skeletal primary tumors. It's much better for metastasis, but if you see one, always think chondrosarcoma, and if you're forced to give a differential lymphoma, multiple myeloma, and osteosarcoma are also common ones. And those that tend to cause a lot of destruction usually are neurogenic or vascular tumors. So here's a very classic chest x-ray. You have this guy that comes in, left-sided chest pain, and all we see is absence of that portion of the rib. Now when you start looking a little bit closer, you see the pleural reactive changes, you see the mass associated with this, and this was metastasis from colon cancer. And then another one, if you just rotate this patient just a little bit, you can see how this abnormality could hide underneath the inferior angle of the scapula. So in this one, you have to be a little bit lucky. We biopsied this one, and this was plasmacytoma. So always remember that regardless of the age, you always have to consider the possibility of metastatic disease. So I'd like to conclude by saying, always think of the musculoskeletal conditions, because they actually constitute a big percentage of patients that come in with acute chest pain that will initially be considered of cardiac origin. I think a systematic approach might be from outside in or from inside out, just as you would with the intrathoracic contents, but you need to adopt some type of strategy for the bony thorax. Always consider that the pain may be referred, for example, with the cervical rib, and CT and MRI both have outstanding roles for further evaluation. Thank you very much. And now it's my pleasure to introduce our next speaker, Bharti Khurana, and she will be speaking on hip pain in the emergency room.
Thank you, Joe. So my job is to speak on usual topic, acute hip pain in the emergency department. So in the next 30 minutes or so, I'll be talking about imaging patterns of common fractures and soft tissue injuries resulting in acute hip pain, going over some non-traumatic causes of acute hip pain in the emergency department, and focusing on what not to miss, what not to misinterpret, and what to really put down in the report. So let's start with the anatomy of the hip joint. It's a synovial joint. It's a large synovial joint, and unlike shoulder joint, it's a very stable joint. We have a large acetabular socket, and then we have the femoral neck, which is more like a pyramid, and greater, lesser trochanter, and the intertrochanteric line. Now, because of its stability, we don't see a lot of dislocations, unlike shoulder. And if you have fracture in younger patients, it's usually intertrochanteric or acetabular fracture. But as we get older, we are prone to develop femoral neck fractures. And the importance of hip fracture is reflected by the statement from the last century: we come into the world under the brim of the pelvis and go out through the neck of the femur. Let's see where we stand in 2013. Now we have very high incidence. We have approximately 250,000 per year in the United States only. And the incidence is going to increase. We have elderly population with increasing lifespan, and the population is very active. There are a lot more medications which make them prone to fall. A delay of only 2 days where treatment is indicated can double the mortality. Post-traumatic osteonecrosis can develop in at least 30% of patients if the fracture is displaced. And current recommendation is to treat all these fractures within 12 hours. Now, obviously, this is a misnomer. Hip fracture, joints don't fracture, bones fracture. But when you think of hip fracture in the emergency department, I want you to think of pelvic fractures as well. And these can be in pubic rami, sacral, supraacetabular, parasymphyseal, iliac, and ischial bones. When we talk about proximal femoral fractures, they can be in head, subchondral or osteochondral, femoral neck, classic division, intracapsular and extracapsular. Intracapsular, we have subcapital, transcervical, basicervical, and extracapsular, intertrochanteric, greater and lesser trochanterous, and subtrochanteric. Now, it's important to understand the arterial supply of the femoral neck, because this is the main reason we want to treat them urgently. So obviously, the major supply is coming from the medial circumflex femoral artery, because it makes a posterior arcade at the base of the femoral neck. And remember, this posterior arcade is not intracapsular, it is extracapsular. So it gets stretched every time there is dislocation. If there is fracture, it can disrupt the lateral epiphyseal arteries, which come from the medial circumflex femoral artery. And then there is an obturator artery, which is not that significant, especially in adults. So proximal femoral fracture, let's go over osteochondral, subchondral, subcapital, transcervical, basicervical, greater and lesser trochanter, and intertrochanteric. Now, intracapsular femoral neck fracture comes in various flavors. The most common is subcapital. Transcervical is very rare, and basicervical is extremely rare. Now, the importance is when you have subcapital and transcervical fractures, they are treated as intracapsular. But if you have basicervical, that's treated as extracapsular. I remember spending a lot of time in deciding whether the patient has basicervical or intertrochanteric fracture. And when I sat down with my hip surgeon, he told me it's not important for him. In fact, it's important for him to differentiate whether the fracture is transcervical or basicervical, because transcervical is treated as intracapsular and basicervical is treated as extracapsular. And sometimes in the emergency department, we are doing these traction views to differentiate transcervical and basicervical. So let's see, this is the classic appearance of radiograph in the emergency department. There is external rotation, and despite external rotation, we see a fracture. There is no femoral neck. I don't see any femoral neck because there is foreshortening. Typically, the greater trochanter rotates externally, and there is pulling of the shaft, and you don't see the neck. Now, this is important to understand that the foreshortening doesn't mean that there is a lytic lesion, and it doesn't mean that there is a basicervical fracture. Most often, these fractures are subcapital, and because of the rotation and foreshortening, they would appear as basicervical or transcervical. This is the classic groin lateral view where you see the head rotated posteriorly. Now, when it's a displaced fracture, it's easy to diagnose. So here is a displaced fracture in varus. This is another displacement, and this is a displaced fracture. Notice that how this fracture, because of distraction, it almost looks like a lytic lesion. But remember, it's just because of the degree of rotation. There is the subcapital fractures are rarely pathological. Most often, it's because of the distraction and rotation. Now, most often we see valgus impaction, and I want to show different kinds of fractures which can fool you sometimes. So, if the fracture is impacted in valgus position, typically the femoral head rotates laterally, and you see this classic beak. Here is another patient where you have classic beak, but then look at the fuzzy margin. This is not an osteophyte or ring of osteophyte. This is ill-defined sclerosis, what we see with fracture. The osteophyte ridge is sharply defined, whereas the sclerosis, because of fracture, is ill-defined. Here is another fracture. Look at the beak, and this is the sclerosis we are seeing, but there is disruption. Another one, this is very subtle, just ill-defined sclerosis. Again, you have to follow your trabecula to see the distortion. So these are more obvious fractures with more impaction. So this is significant impaction. Another one with less impaction, slightly more distraction. This is more distraction. And here's another one. Actually, this is a complete fracture because it's involving the medial cortex. Now, this can be a problem sometimes. Actually, sometimes it's hard to convince the clinician. You see this abnormality, it looks like a mushroom sign. We see this extra bone here. It's not an osteophyte. There is no joint space narrowing. There is no osteoarthritis. And you call this fracture. And sometimes it's hard to convince clinician. And in these cases, you can do CT and show the impacted fracture. So CT was done in this case, and there is sclerotic line. And remember, these are impacted, incomplete fractures. So our eyes are used to looking for lucency, even on CT, and we tend to miss these fractures. So we are not looking for lucency when we are looking for impacted fractures. So they would come as sclerotic line. So this is varus impaction. These are less common than valgus, but again, look for those because they can get missed. Another one, this is more displaced, and there is a lucency laterally. So we were talking about the stress lines, and we have the trabecula. So compression trabecula, tensile trabecula, and compression is more, if you see these trabecula are more vertical and in triangular configuration. The tensile trabecula are more arc-like. And then we have this Wart's triangle, which is where there is paucity of these trabecula, and that's why we see fractures here. Now, what not to miss? Here is a case where we have superior and inferior pubic rami fractures, but an impacted fracture in varus impaction was missed. This is another case where greater trochanter fracture was called, but unfortunately subcapital femoral neck fracture was missed. This is another case where soft tissue fold was mistaken, and fracture was mistaken just as a soft tissue fold. And sometimes, despite following all the rules and lines, we just don't see fracture. Here is one such case, and in those cases we do MRI and see fracture line. And we call these fractures as occultive fractures. Here is another case. We have soft tissue fold exactly where I want to see the fracture, don't see any line, and then we do MRI. This is another example of occultive fracture. Now, we all know the difference between occult and missed hip fracture. If you read the film, that's an occult fracture, but if your partner has read the film, that's a missed fracture. So what exactly is an occult hip fracture? It's an incomplete fracture or complete fracture without displacement. It could be a microtrabecular stress fracture with intact medial and lateral cortices. It's more common in elderly with osteoporosis and minor trauma, and I find this a trap for radiologists. because ER is not really worried about fracture because there is no significant trauma. But these are the patients exactly where you would not see fracture on radiographs, because remember, there is no trauma, there is low energy trauma, the fracture may not be displaced. And because of osteoporosis, you may not see that fracture line. The incidence reported in literature is 2 to 11%. But just to give you perspective, when we did our study, we saw 28% of MRI studies were positive for fracture, 64% fractures were seen in pelvis, and 36% in femur. Now, what options we have to image occultive fracture? Traditionally, we have always done delayed radiographs, follow up in 7 to 10 days. But obviously, that doesn't match with our current recommendation, which is to do treatment within 12 hours. Scintigraphy is great, it's very sensitive, but it has poor specificity. And unfortunately, it has to be deferred up to 24 hours in elderly and osteoporotic patients. Actually, these are your major patients or patients on steroid therapy. And the whole study can take up to 4 hours. We have CT. CT is easily accessible in ED, but I'll show you some examples. So here is a fracture on CT. Easy to see, we have distraction, displacement, and these are the fractures you would see on radiographs anyway. Then we have fracture like this, very hard to see. And this is an impacted fracture. And I find actually impacted fractures easy to diagnose on radiographs than on CT, maybe just because I'm used to seeing on radiographs. But this is something I feel like, especially if you're not very experienced and you're not looking for fracture on CT, you can completely miss it. Because again, our eyes are not trained to look for sclerosis as fracture. We are just so trained to look for lucency. Here is another one. Fracture may be seen only on reformation, depending on the plane. So make sure you are reading your CT images almost like plane radiographs, every image. This was actually seen only on one image. And this is another example, impacted fracture seen only on coronal reformation. Now, why is it easy to see fracture on MRI? Well, the fracture doesn't rely on cortical or trabecular displacement. It is based on presence of edema around the fracture site. Linear pattern edema would favor fracture over contusion. And we have all protocols. Routinely we do bilateral hip, unilateral hip. In the emergency setting, we have been doing abbreviated hip MRI, which would include just STIR and T1 coronal, and some, in many places, T2 fat set axial can also be added. But remember, these are large field of view. And why we chose coronal was because coronal is only sequence which would include entire pelvis, because axial and sagittals can miss the iliac crest and sacrum. And we think the STIR is essential because look at this example where there's hardly any edema in the on proton density fat saturated image, and we can see that edema nicely on inversion recovery. Now, is MR one-stop shopping? Actually, this was a recent case where we had some tendinopathy of the gluteus medius, some reactive marrow edema, a little bit of trochanteric bursitis. We did follow-up radiograph, and we saw this fracture lucency. And then CT was done, and we saw this fracture. So just like in spine or ankle and several other joints, MRI is not good for pure cortical avulsion injuries. Routinely in spine, even though we have MRI, we end up doing CT to look at those small cortices or even avulsion fractures. So we learned a lesson by doing this because retrospectively, I could see this tiny fracture. And again, if you're using MRI looking for fractures, you have to read almost like plain films looking at every image. And again, this was seen only on one image. There are some pitfalls. This shouldn't be a problem because we are looking at significant osteoarthritis with femoral neck ring of osteophytes mimicking fracture. And unlike our impacted fracture, there is significant joint space narrowing. This was the case actually I overcalled. I thought this was a fracture, but there was no history, there was no concern. An MRI was done, and this was just a sclerotic lesion. Patient had, extensive metastatic disease, and this was just a lesion. Here's another one. Actually, this was called outside as head contour abnormality, and fracture concern was raised. And this is the case. We did MRI and proved that there was no fracture. It was just an osteophyte. And again, if you have any doubt, again, you don't want to miss. But if you have doubt, you don't want to mistreat these patients too. So it's a good idea to do cross-sectional imaging. And you need correct view. So don't compromise if the patient is externally rotated. You need to see neck like light bulb. So you need to have internal rotation. So I want to go over terminology here because there is some misconception here. When we talk about stress fracture, it can be an insufficiency fracture, which is normal activity with abnormal bones. So think of your mother or grandma, maybe, where the bones may be osteoporotic or osteomalacia, or they're just not normal bones. So even normal activity would cause fracture. And these are more commonly seen in pelvic bones. Then we have fatigue fracture. So these are high core athletes, highly motivated runners who tend to do abnormal activity on normal bone. So femoral neck is a very good site for those fractures. So femoral neck fracture, stress fracture, and this is the distinction actually I learned from my pelvic surgeon. It's quite important. So you can have a compressive fracture, which involves more the medial femoral neck, and that's considered stable. And then you have tensile, which involves more the supralateral cortex. This is actually a really bad fracture and has to be treated immediately because they tend to displace, just like this fracture. So this is displaced, unstable, they are prone to develop AVN. So let's see the examples. So this is a classic compressive fracture. There's marrow edema, there's some cortical thickening, and so this is what we see with stress or fatigue in highly motivated runners. And then if you do radiographs, with follow-up radiographs, you would see some cortical thickening as the phase of healing. This is another case, more subacute, where there is more sclerosis and still marrow edema and thickening on the radiograph. And sometimes you may not even see fracture. You would just see marrow edema beneath it. This we call stress reaction. And stress reaction is nothing but just microtubercular stress fracture, which we are unable to see, even on MRI. And again, these patients, so this particular patient, you can just, you may not even have to do surgery because these fractures tend not to displace because they're in compression mode. And, there is no need to do surgical treatment. Unlike this patient. So look at this. This is a tension-sided involvement. And this is just a subtle lucency involving the lateral cortex. But this fracture tends to displace. Here is another example. So we see this tension-sided non-displaced fracture. And again, radiographs were normal in this case. And this is actually an unfortunate case. And that's why I sometimes feel in young women, there's some blurring of fatigue versus insufficiency fractures, and especially because of combination of anorexia nervosa and if you have a very highly motivated runner. Because this particular patient actually came with the disc from outside imaging center and had this fracture involving the tension-sided femoral neck. And by the time we imaged her on radiograph in the ED, she was already displaced. So she's prone to develop AVN because it's a complete displaced fracture. And I was told that the day she got this MRI, she was running, preparing for marathon. And in fact, her radiograph was normal a week before, so that gave her more comfort that there is no fracture. So how do they manage femoral neck fracture? So it depends whether the fracture is non-displaced or displaced. And it also depends if the patient is young or old. So in my dictionary, young is anyone less than 65, because we are not talking about chronological age, we are talking about more biological age. So if you're active, you'll be treated exactly like a 30-year-old. The goal is to preserve femoral head, avoid osteonecrosis, and achieve union. So if it's non-displaced, the surgeon would do percutaneous fixation. They'll just put 3 pins and stabilize the femoral neck. If it's displaced, then he can put these 3 pins under, it would be more internal fixation. And if you are old, more than 75, then the goal is to restore mobility and minimize complications. And again, you can do percutaneous fixation. If it's non-displaced, if it's displaced, then arthroplasty. Now, the other thing what I learned from our surgeon is they don't use Gordon's classification. We use it for radiographs, but this is the classification they more often use. And once I understood, I started putting that in my report. So if you have fracture line more horizontal, this is relatively more stable. But if you have fracture, a little bit oblique, that's still, it's between stable and unstable, but that's actually the most common fracture. And then the type 3, when you have vertical, that's the most unstable. And now you have the knowledge of trabecular lines and the involvement of the tension-sided cortex and compression side. So you know that if you have horizontal orientation, the fracture is in compression, so it won't get displaced. Unlike vertical fracture, which can easily get displaced because there is shearing force. So much so, if you have a fracture like this, sometimes they create a horizontal fracture by doing osteotomy, so that there is healing in compression mode. Intertrochanteric fracture, Stephen, I'm sorry, the timer is not working. It's still 20. Okay. So intertrochanteric fracture can be, so they use modified Evans, and I don't use the classification that often, but it's more, you should know that if you have involvement of the medial cortex, the calcar, that's important to mention. And obviously if you see more combination, and if you have subtrochanteric extension or reverse obliquity, it's worth mentioning. So greater trochanteric fracture, this can be very hard. So here is a non-displaced fracture. And again, you have to look for this fracture. This will not jump on you. Here is another patient with more comminuted, slightly easier to see. Then this fracture where there is extension. So if you have extension, again, you would not miss it. And again, if there is displacement, easy to see. And remember, these greater trochanteric fractures, they don't do anything if it's just in the greater trochanter. If it's displaced by more than 1 centimeter, then they would do surgical fixation. So even on CT, they're hard to see. There's a lucency here. And again, it may be seen only on reformation. There is sagittal reformation, and axial also, you have to look for it. So easy to see on MRI if there is involvement of the cancellous bone, as in this case. And so this fracture is not going to the cortex, to the medial cortex, unlike this fracture, which is extending all the way to the medial cortex, and this would be considered as intertrochanteric fracture. So the concept of incomplete fracture has emerged from MRI, actually. So I was told by my pelvic surgeon when we were first diagnosing these fractures, they didn't know what to do because it wasn't reported in orthopedic literature. We were seeing these fractures. So the current recommendation is if you have extension to the medial cortex, they would fix it. If it's not extended, then they would just follow up, or patient is on protected weight bearing. So these are called incomplete fracture, and again the idea is, and you would see more and more in your practice, anytime you see greater trochanteric fracture, they would like to do MRI to see the complete extent of fracture line. Lesser trochanteric fracture, again, every time you see, raise the concern for pathological involvement. This is a patient with the diffuse sclerotic metastatic disease because of prostate, and there is an avulsion fracture of the lesser trochanter. Subtrochanteric fracture, so any area beyond this lesser trochanter to 5 centimeter distal is considered subtrochanteric. Subtrochanteric fractures are usually comminuted, they are spiral, and typically there is significant shortening because there is a lot of overlapping. And these are hard to fix too. So obviously these fractures you would never miss. But then we get fractures like this, where these are more transverse, there's not much combination, and there is medial spiking, which is very characteristic. And there's thickened lateral cortex, and these patients don't have significant history of trauma. We call these fractures as atypical subtrochanteric fracture. And there is, actually this is from 2013 JBJS. So you have to have all those major criteria to call as atypical, and these are seen in patients with bisphosphonates, and there are other comorbid conditions. But important thing is I was told by my surgeon not to call them bisphosphonate, just call them atypical femoral fracture. So here is one example. This is the classic osseous bump. Osseous bump is nothing but basically these are insufficiency incomplete fractures. And we followed this patient. So 6 weeks later, patient came with fracture in the emergency room. And what happens is anytime you see a subtrochanteric fracture, which is atypical, the surgeon is going to fix this fracture, of course, but then he would order the contralateral side too. So it's a good idea to do the contralateral hip to see this tiny osseous bump which reflects insufficiency fracture. This is another patient, but in this particular case, this is a transverse fracture, but this was a metastatic lesion due to lung cancer. And this particular patient had diffuse breast disease. It almost looks like Paget's disease, but this was all sclerotic metastatic lesion. And we have this classic lateral cortex involvement. So just a little bit about the posterior hip dislocations. Again, they are not that common, but they are seen with high-speed MVA. And, you won't miss the hip dislocation, but it's important to talk about what kind of fracture you are seeing on your images, whether it's involving so the surgeons use Pipkin classification. And again, I'm not telling you to use this classification, but just understand the important things. If you have a fracture below the level of, fovea or ligamentum teres, that's not important. They would actually not do anything for that tiny fracture. But if you have fracture involving the weight-bearing surface, which is above fovea, then they would fix that kind of fracture. And again, look for your femoral neck fracture and posterior acetabular fracture. So all these fractures are going to be fixed. So here is one example where we have, and you remember that ghost sign, so you almost look like, another femoral head sitting here. And this femoral head is involving, so there is fracture involving the weight-bearing surface, and the surgeon has fixed it. Occasionally we see subchondral stress fracture if you're doing MRI in the ED, and these are just tiny convex fractures with a lot of edema. In fact, we used to call these as transient osteoporosis. And most often if you see all those patients, actually we went back and saw that many patients had this signal abnormality. So you should know how to differentiate subchondral stress fracture from AVN, and it can be very difficult sometimes. But in general, if you have convexity facing up, that's subchondral insufficiency fracture. But if you have concavity, that would be AVN. And again, these patients are followed up, and some patients you just lose the signal, and unfortunately some patients continue to get worsened and develop AVN. So more often than not, we see lateral compression injuries. In fact, nowadays, when we are doing MRI in the ED, we see the same pattern. So you will see superior and inferior pubic rami fractures, and the sacral fracture can be very subtle. In fact, anytime you have superior and inferior pubic rami fractures, our surgeons would like to do CT, especially in young patients. Elderly patients, they may or may not do, because those sacral fractures are not displaced. And these sacral fractures, again, you have to look for it. On CT, X-rays, they are always hard because of bowel gas, but again, you look for your arcuate line disruption. But even on CT, these can be subtle. Just one lucency. Sometimes you see just a small buccal fracture. So let's go over insufficiency fractures of the pelvis. It can be in sacrum, classic Honda sign, supraacetabular, superior pubic ramus, inferior pubic ramus, parasymphyseal, and ischial. So pubic rami fractures, again, if you're doing MRI, especially abbreviated hip MRI, get used to their appearance on coronals. So here's a classic superior pubic ramus on coronal, and this is same thing for the inferior pubic ramus fracture. Sacral stress fracture, we just talked about, easy to diagnose on MRI, but this is the buccal appearance I was talking about. Sometimes you may just see cortical buccal on CT. Supraacetabular fracture can almost look like a metastatic lesion, but once you know the classic site, you would not get fooled. So here is a classic insufficiency fracture. And again, these fractures are multiple. Just don't stop at one fracture. So look at this patient. Patient had the supraacetabular fracture, femoral neck fracture, intertrochanteric fracture, contralateral femoral neck fracture, but another supraacetabular fracture, and bilateral sacral fractures. So keep looking for these fractures because they are most often multiple. So let's just go over, now that we are doing more and more abbreviated hip MRI in the emergency department. So always try to think of posterior and anterior arches because you're looking at the pelvis. So start from posterior, and immediately you would look at the sacrum, and there's a non-displaced sacral fracture with a lot of edema. Then we continue to go up, actually continue to move forward, and then we'll start seeing this inferior pubic ramus fracture with marrow edema, and then we have the superior pubic ramus fracture and parasymphyseal fractures. So most often these fractures are multiple. So briefly, I'll talk about the periarticular muscle injury because I don't know how much time I have. So again, when you're thinking of muscles, think of groups. So lateral muscles, medial muscles, anterior and posterior muscles. Here is a gluteus minimus avulsion, again, commonly seen in elderly patients. This is gluteus medius avulsion. So gluteus medius is more posterior superior and gluteus minimus is more anterior. This is adductor longus in young patient, presenting with athletic pubalgia, and once in a while they come to the emergency department, and this is adductor longus avulsion. Iliopsoas tear is actually very common. We are seeing this in elderly population, elderly women specifically, and so this is, look for the retraction here. Hamstring tear, in fact, my surgeon told me that this is only one exception where they would fix the patient urgently. So, we do MRIs just to look for hamstring tears. So non-traumatic causes, here is a young patient coming with hip pain. I didn't see anything other than just little sclerosis along the SI joint, but I was surprised to see her MRI. Here is all this edema and huge abscess. So there's myositis and abscess sitting in the iliaca. So this was sacroiliitis. It's actually the septic arthritis. Here's another young patient, unfortunately. By the time he came to the ED, this was his appearance. So he had the severe osteoarthritis on one side, and there's loss of subchondral plate, classic appearance for septic arthritis. And this is another patient with a lot of marrow edema and abscesses. So, you see these calcific tendinitis, and we used to call these as just calcific tendinitis, but more and more we are seeing when they ask for MRI, we are seeing that how much inflammation the calcific tendinitis can cause. This is another one with calcific bursitis. Again, I was very surprised. The patient was very symptomatic. They wanted to do MRI. And look at the extent of edema we have with this little calcification. So they're clearly symptomatic. And of course, metastatic lesion. This is the subluxation because of metastatic disease, and there is an complete destruction of the superior pubic ramus. And then we have sclerotic acetabular lesion due to prostate cancer with pathological fracture. So here's my checklist. Look for anterior and posterior arches, regardless of your reading X-ray, CT, and MRI, because you just saw all the examples. Fractures can be very subtle. Look for the femur, and then look at the soft tissues. Think of more groups. And again, don't forget to look at all the corners. This was a shaft fracture which was missed on MR. So look at all the corners. And I want to thank all my co-authors on this paper and also our pelvic surgeon. So thank you. I hope I didn't take your time. So it's my honor and pleasure to introduce Dr. Linau, who would be speaking on foreign bodies and extremities, an unusual topic.
Thank you, Bharti. Home stretch. So when we think about retained foreign bodies in extremities, I'm going to speak about retained foreign bodies in the extremities in the broad sense, not in the strict sense. I acknowledge my coworkers for this topic. So when I was in residency and fellowship, I heard a lot of confusing things about foreign bodies. They can't be seen radiographically, they can be seen, and so on and so forth. But there is another rationale for thinking about foreign bodies in extremities, and that is because when foreign bodies are retained, they usually cause harm. In many cases, they cause inflammation and infection, and there have been case reports where long-standing retained foreign bodies have caused tumors. Less severe restriction of motion and function may bother the patient, and it may be very uncomfortable for the patient to deal with that foreign body in his extremity. Therefore, radiologists are often asked to locate foreign bodies and aid in their removal. When we think about foreign bodies, we also always have the armamentarium that we usually have at hand, including radiography, sonography, CT, and MR. So what's best? To get to the bottom of this, we set out and we went to the butcher store. And we bought a ham, and then my colleague Chris Ingram, who has a surgical background, spiked this ham with a defined set of foreign bodies and we sent it through the MR scanner, through the CT scanner. We looked for the foreign bodies with ultrasound and with radiography. We ended up with this pathologic radiological correlation, and we used fish bones, different kinds of plastic, several different kinds of glass, and many different kinds of wood to see what we find. We then tabulated our findings, and we came up with this very helpful bedside tool, which on the one hand side shows you what foreign bodies we used, and it tells you how visible they are on the different modalities. And in the next 25 minutes or so, I'm going to dissect this table with you, illustrating it with clinical cases. So there's one urban legend. It has been said that trout and halibut foreign bodies or fish bones of the Salmonidae or the halibut species are not visible very well on radiographs. Here's a salmon bone and a halibut bone. We stuck this into the ham, and here it is on close-up. And yes, you can see them both, the salmon as well as the halibut. More importantly, when you know where your foreign body is, you can see it with ultrasound. It will show itself as an hyperechoic structure with a dorsal acoustic shadow. Similar for the halibut bone, echogenicity, dorsal acoustic shadow. Here's a clinical case, and this Native American woman had a large salmon meal. After the meal, she said, well, I feel a foreign body sensation in my throat, and sure enough, on the lateral radiograph of her neck, you see the salmon bone stuck in her pharynx, and this was subsequently removed on direct visualization. This is a picture of the Pike Place Market, and those of you who have been to Seattle will know that at the Pike Place Market there are several fish dealers who make it an attraction for everybody that wants to watch of how they throw the fish from the display in the front to the back of the counter where the fish is filleted and then packed for you to take home. And as you can see, there's a large crowd watching. In fact, this is so popular that once or twice a year the public is invited to participate in a fish throwing contest. And this is exactly what this young woman did, and her husband threw her a salmon, and the salmon, she caught the salmon, but unfortunately the salmon pierced the antecubital fossa, and we see on the elbow radiographs that were obtained in our emergency department that there's a bone in the soft tissues. Easily recognized on radiographs, subsequently removed. She went on her vacation. Fishing can be dangerous also because fishes are hooked with metal hooks. If the fish hook is in the superficial soft tissues, like in this case, it's no big deal and it can easily be removed. However, if the fish hook is embedded in the bone and may affect the flexor apparatus of the hand or the fingers, then it is more complicated and may require surgical removal. And not all hooks, fish hooks, are actually fish hooks. This guy tried to repair his radio with an ornamental hook and it got stuck in his palm. This guy was a skier and he crashed into a tree, and on our trauma series in the trauma bay we see this ornamental hook that he had brought back from New Zealand, as my colleague Martin Gunn, who is from New Zealand, tells me. So what happens if we overlook a fish bone? So this is an intraoperative image of a guy that was fishing for trout and got injured when he filleted the fish. Unfortunately, this was not recognized on his first visit a month earlier, and he ended up generating a foreign body reaction which then had to be removed surgically because it was thought that it might interfere with the flexor tendon sheet of his middle finger. Here's the fish bone. Here's the surgeon localizing it with a needle, and now here it is out. This is the original image from 1 month earlier. You clearly see the bone there. This is in close-up, and here's the intraoperative 1 month later picture. Looks very similar, unfortunately missed. And then there's the unusual presentation of the fish. This gentleman came to our emergency department with stridor and respiratory distress because he had tried to swallow a whole live fish. And you can see the soft tissue attenuation in his pharynx with the bones of the fish in the middle, and unfortunately the spiky bones in the dorsal fin of the fish had pierced his pharynx and had caused retropharyngeal soft tissue emphysema, which was confirmed at surgery when they removed the fish. Switching gears, let's consider this painter. We know that he's a painter because there's pigment residues on his fingertips and under his nails, but more importantly, there's also paint pigment in the soft tissue fingerberry of his left thumb. He had pointed his paint gun at the non-dominant hand and had injected himself with a small amount of paint. High pressure injection injuries are usually seen in men. They usually occur in the non-dominant hand, and unfortunately up to 30% of these injuries require some sort of operation. Because the surface injury or the skin defect that is associated with these injuries, the skin injury is very, very inconspicuous in many cases because it typically has a pinhole appearance. But the full extent of the injury is usually much larger than the physical exam may suggest. And that is why these injuries are always surgical emergencies and require the consultation of an experienced surgeon. They do worse if the solvent that is injected into the hand or foot or arm is of an organic solvent such as a paint thinner, paint, or the derivatives of gasoline, because these substances will cause necrosis and thereby increase the chance that amputation is necessary. It is also important to recognize that fingers other than the thumb or the palm put the patient at increased risk for amputation, up to 70%. And surgical consultation that is delayed, which delays the debridement that may be necessary, also increases the amputation rate. So here's a clinical example. The skin defect is very innocuous, hard to see, but if nothing is done, extensive necrosis can occur. This is the radiographic correlation. Sorry, I apologize. So the radiographic correlation of a similar injury shows that the paint pigment in these patients may be much more extensive, extending from the second phalanx down to the palm, while the skin defect may be tiny and small. Here's another example, very small skin defect, but when the debridement is performed, you have a long incision ranging from the fingertip all the way back to the wrist. This is the full extent where the exploration has to occur. And it is not useful if you image your patients with the bandages on. Here's the bandage. Here's a tiny little bit. On a quick look, you might think, well, this is not much paint injected, but the full extent of the injury is only visible when you look really, really careful through the bandage. So take the bandages off if you are confronted with such a patient. Hogan and his colleagues have analyzed all the cases that have been described in the literature back to from I think from the 60s down to 2005, and they found whenever water or air are injected at high pressure, the amputation usually does not need to occur. Therefore, some authors have advocated that if water or air are injected, you can treat those injuries expectantly. Switching gears, talking about wood. When we introduced wooden foreign bodies in our ham, we soaked certain kinds of wood for a week in water, and then the same type of wood we used in a dry fashion. And we used bamboo, softwood, a toothpick, and the hardwood of a tongue blade. Here's a clinical correlate of what you might see, a clinical example. This unfortunate man had an encounter with his table saw. He severed the tendons of his index to small finger, but in his thumb you can see that there's also a barely visible, slightly radiopaque foreign body that traverses the soft tissues of his thumb from the dorsal aspect to the palm. The physical exam is helpful in this case because it's sticking out on the side. In this gentleman, he was chopping wood about a week ago, and when he was chopping wood, a splinter pierced his calf. At the time of the injury, he took out about an inch of wood out of that injury, but then he presented to our hospital with pain and redness in his calf. And I have to commend our technologists who have put a paperclip right where the area of clinical interest is. And that turned out to be very helpful, because if I blow up this image, you see that actually embedded in the skin was a small foreign body that is slightly more radiopaque because it has been sitting there for several days soaking up fluids. This was subsequently removed. In our experiment, whenever we put wood in a spot, we could see it with ultrasound. It is hyperechoic, and there is an intense acoustic shadowing. Here's another one. And even if the transducer is in the short axis or transverse to the foreign body, you may not see the wood itself on ultrasound, but you can see the dorsal acoustic shadowing, which may allow you to make the call of a retained wooden foreign body. Here's another clinical example. He fell, he came 2 weeks later. Sure enough, there is ulnar side soft tissue swelling, and in the center of the soft tissue swelling is a radiopaque foreign body, which turned out to be a wood splinter that is saturated with fluids because it has been sitting there for several weeks. So when you are confronted with wood foreign bodies, we thought that most of the wooden foreign bodies that we encountered were visible on radiographs, but the visibility was somewhat variable. The signal intensity on MR of the wood itself did not help us because we couldn't see it. But that may be a limitation of our study, because when you do MR in a patient, you have an inflammatory reaction which we could not see, of course, because we had no life in our ham. But most importantly, if you know where your wooden foreign body is, you can find it on ultrasound. You may ask yourself, what about CT? Well, let me illustrate this with this case. This gentleman was cutting down a tree. When the tree fell, one of the branches of the falling tree pierced his flank. When he arrived at our emergency department, we took an abdominal radiograph, and you can see the soft tissue emphysema in his left half of the body. This is also visualized on the cross-table lateral view, which was also obtained in the trauma bay. But this is a case where you need to go to CT, because only on CT will you be able to describe the full extent of the impalement that has happened to this gentleman, in which has pierced several bowel loops, including the sigmoid colon. When you do CT and you are looking for wood foreign bodies, it is very advisable to use wide window settings to look for the wood itself. Because when you use a lung window or a bone window, you will be able to see the striations or the rings of the wood on the image itself. Here's a companion case. This boy fell out of a tree. On the way down, he fell onto a branch. The branch pierced his left thigh and went into his pelvis. You don't see the foreign body? Well, here it is. That's what you see on the radiograph. That's the radiographic appearance. If you really, really look carefully, you can see it, but it's much easier on CT. And here we see that this branch went through the obturator ring into the deep pelvis, very close to the urinary bladder. Corresponding axial images, again, you need to look on soft tissue window to see the anatomy, but you need to look on a wide lung window or bone window to see the wood itself. Here is the branch that impaled this young gentleman. Here are the iliac vessels, which were fortunately spared. Here's the urinary bladder that was concerned to be injured, but turned out to be okay. And here's the wood with the rings. We now know that branch was about 10 years old. So CT is useful to describe the anatomy. If there is a deep wooden foreign body, try to use a wide window setting in order to be able to visualize the foreign body itself. And in this case, it may be very hard to separate wood for wood chips from bone chips. Our surgeons decide after seeing this radiograph that it was not possible to to reconstruct this arm, and so the description of the wood chips was not necessary because unfortunately had to go on to amputation. Switching gears again, plastics. Well, we decided to use the resin identification code proposed by the Plastics Industry Trade Association, which allows the recycling of different types of plastic. And I'm sure you're all familiar with these numbers. They're pretty much on every plastic thing that we use in our daily lives. There's a little triangle in the bottom that tells you what kind of resin or plastic is used. This is what the samples used looked like for our little experiment. And fortunately, plastic foreign bodies are very uncommon in the clinical setting. However, many things that we use as healthcare providers that we insert into patients is made out of plastic. And I think that's why it is useful to be familiar with the radiographic appearance of plastic foreign bodies. Here's an example. This gentleman was involved in a high-speed MVC. He was brought to the resuscitation bay. A subclavian catheter was placed, and it's on the right side. Unfortunately, it points upward where the internal jugular vein is, and the internal jugular vein is small and should not be infused with large amounts of fluid for resuscitation purposes. For those of you who remember this movie from the early 90s, they may also remember that there is John Travolta stabbing somebody in the chest. Well, we're not that violent, but almost as violent. When our paramedics suspect a pneumothorax in the field, they used to place what's called a flutter valve. And you see those large bore metal cannulas when patients roll into the trauma bay in the emergency department. If the pneumothorax is large and if the pneumothorax is decompressed, then these things work very well. But if the diagnostic accuracy is less precise, these things can cause pulmonary lacerations and contusions, like in this case of a different patient. And that's why our paramedics, or the paramedics in the area where I work, have devised a different approach. Instead of using these rigid large bore metal cannulas, they use large bore IV lines, which are inserted in the second intercostal space, but then the stylet and the needle are retracted and only the plastic tube is left behind. And this is what they look like. The decompression is the same. As the patient is brought onto the ambulance, this plastic tube is hooked up to the suction, but the metal part of it is removed from the patient. And then when we consider that this 24-year-old motorcyclist who hurt her elbow, we see that she has soft tissue swelling at the level of the elbow, no fracture. You do not want to mistake this for this tubular structure for a retained foreign body, because this is not a retained, well, this is a foreign body, but it is there for a reason. It has been placed by a healthcare provider for long-term contraception. And nicely, the manufacturer has included a small amount of barium into the carrier material of this thing so that it is more visible on radiographs. When you know where your plastic is, you'll find it with ultrasound. For the last part of this talk, I want to talk about things that usually are more radiodense. We shouldn't have difficulty finding these foreign body. Well, quick show of hands, who sees the foreign body in this case? It's right there. So as is always the case, a second view is a golden view because the frog-leg lateral clearly shows the retained needle fragment of this IV drug user. Here are some companion cases: antecubital fossa, several needles in the antecubital fossa. Here's one in the foot, and if you run out of extremities, you may inject into the veins of the neck, and then this may be the appearance. What about this one? Well, this, also an IV drug user, came to our emergency room with bilateral hip pain. When she got her CT, we see that there is a metallic foreign body, again, a retained needle fragment, just as like the others that I just showed you. What is important is they wanted to know, well, is this the explanation for her hip pain? Because the vasculature is over here, and in this case it was helpful to have thick MIP reconstructions because you can see that the veins and the arteries are far away from this needle fragment, which is not the cause of her elevated white count. The cause of her elevated white count is the septic hip on the contralateral right side. This gentleman had a very unusual presentation. He woke up from after using heroin and complained of acute sharp chest pain. When we asked the history about this, about the incidents, he told us that he had injected into the left hip, fallen asleep or fallen into his dream, and when he woke up he couldn't find that needle anymore. Well, on the pelvic radiograph there's a needle there in his left hip where he injected, but it doesn't explain his chest pain. So he got a chest x-ray, and on the chest x-ray, sure enough, there's the needle embolized into his pulmonary arteries, visualized radiographically, and on CT, in this time displayed in a bone window, we see the needle in the pulmonary parenchyma. Again, I find it very helpful to visualize those foreign bodies in thick MIP reconstructions because it shows you the entire extent of that lesion. This is a different case. The radiograph was sent to us from the operating theater after the end of this unfortunate 26-year-old's amputation of the upper extremity because the needle count was off. And here we could help the surgeons in identifying the foreign body that was causing the abnormal needle count. When we looked at this, initially we didn't know what to think about it. But zooming in, we could identify that this was in fact the lid of a chewing tobacco container that remained in the shirt pocket of this patient, and so it is not actually a foreign body, but it is a metallic lid away from the bone. A few words about glass foreign bodies. They are usually visible on all imaging modalities. This is the typical appearance of autoglass on radiographs, polygonal shaped, radiodense, and this is what they look like when they're removed, just like on the street when you have a car crash. Interestingly, we found that some types of windshield glass, if it is tinted, causes a large amount of MR artifact. A 5 millimeter foreign glass fragment of tinted autoglass will cause almost 5 centimeters of artifact on T1, on T2, and on stern. This window washer fell off the ladder, fell through the window, and on radiography in our emergency department, there's a piece of glass embedded in his distal radius. After removal, we confirmed that all the pieces had been taken out. This lady tried to catch a heat lamp as it was falling towards her, but when she caught it, the bulb shattered. I'm showing you this example because when you are dealing with thin slivers of glass, they may not be as radiodense as you expect, because in this case there's a 3 centimeter shard of glass in the palm of her hand that had penetrated through the skin and into the soft tissues, and again we could show that we got it all out after the removal of the glass foreign body. This young lady refused to take off her jewelry when she fell from her bicycle and complained of hand pain. She claimed that this ring was too valuable to be taken off. She's not the first person that was imaged with X-rays. In fact, one of the first X-rays that we ever got in the world also showed a ring on a finger. But the question is this a real ring or is it a fake ring? Well, we put this to the test with the help of my colleagues Karen Gray and Joy Duro. Diamonds are made out of carbon. Carbon has an atomic number of 6. Zirconium has an atomic number of 40. Therefore, zirconium is much denser. In addition, the making of zirconium crystals requires metallic oxide stabilizers such as yttrium oxide, which is also much more dense than real diamonds are, and this is why cubic zirconium oxides are radiodense and real diamonds are radiolucent. So her ring, in fact, was valuable. This can also be important for the clinical setting, and this is a case to illustrate this. This is also my last case. This lady crashed her car and was brought to our emergency room. She wears a common jeans brand that uses an inverted triangle, and guess what? There is a lock-picking key in her pocket. I would like to draw your attention to the gluteal fold because there's no radiodense material in her gluteal fold. So she complained about abdominal pain. She was taken to the CT scanner. We got a CT scout, and on the CT scout, suddenly a ring shows up. So she had been moving an object around that she obviously wanted to hide from us. So let me zoom into this ring for you, and sure enough, it was a diamond ring that later turned out to be a stolen object. So to sum it all up, in our experience, most foreign bodies in extremities are shown on radiography, and I think starting with X-rays to localize the foreign body is a good idea. CT is the most useful tool to determine the relationship of a deeply impaled foreign body and to determine what the surrounding anatomy is. If you know where your foreign body is located, and if it's accessible with the depth that ultrasound allows you to access, you will find it with ultrasound. In our experience, the foreign bodies that are imaged in the extremities that are usually not seen with MR. And you may find our table useful. If you want to use one, email me, and I will send you a PDF of it. I thank you for your attention. Have a good evening.